Today we'll talk about something that unfortunately we see fairly commonly in a colorectal practice, and that is the diagnosis of colon cancer. It must be noted that you need to differentiate colon cancer from rectal cancer and from anal cancer. This is based on the location of the lesion, and these lesions behave very differently. In fact, some of them are squamous in nature. From their very biological and cellular structure, they're very different, but also from an anatomy standpoint, these have vastly different structures around them, which may or may not be involved in the disease process, and their lymphatic drainage can also be significantly different. Now, coming back to colon cancer, it's unfortunately fairly common. About 1 in 15 to 1 in 20 individuals in the US will get colon cancer at some point. And we know that these form from polyps, and we know we can visualize polyps and treat polyps before they become cancer. So that has led to a rigorous screening protocol where we are trying to prevent colon cancers, and in case where we are not able to prevent colon cancer, we're trying to find them at earlier stages where they're better treated and cured. The cure rate for colon cancer is based on multiple factors, but particularly how early you catch it. Once the cancer has gotten to the lymph nodes, the cure rate goes down, and once it's gotten to other organs, it goes down significantly. Even in those settings, it behaves better than some of the other more aggressive cancers such as pancreatic and esophageal, and it does tend to respond to chemotherapy. However, again, we know that we get a significantly higher cure rate if we can catch it before it's metastasized to lymph nodes and other organs. And as such, currently we advocate screening individuals with colonoscopies to look for malignancies and to look for polyps. And ideally we find nothing, but if we find polyps, we go ahead and remove them, because 1 out of 4 polyps become cancer at some point, and we don't know which ones. And we do know if we remove them, then they won't become cancers. In individuals who are found to have colon polyps, we do more routine and more aggressive colonoscopies, because we know in individuals you can go from normal tissue to a cancer in about 3 to 5 years, more around 5 years usually. But if you have a history of colon cancer within your family or other genetic predispositions, then that pathway from normal tissue to cancer can be accelerated. So based upon a good history, we may advocate vastly different screening regimen where individuals get started on screening much sooner and have it much more frequently. Cologuard is another way of screening for colon cancers, which has come into the fray over the past couple of years, and we're utilizing it, but still gathering information about its efficacy and its role within colorectal cancer screening. Again, colon cancer is fairly common, and hopefully we can screen enough individuals to minimize the rate. And as long as it hasn't gone to other organs, resection can be curative. And if it has spread to lymph nodes or other organs based upon staging, then chemotherapy is advocated. The role of radiation therapy in colorectal cancer is minimal and very, very individual.